All right, on this video, let's talk about how to perform a basic point of care pulmonary assessment utilizing ultrasound. So you can get away with any of the three probes. On an adult, we're going to be mostly sticking to the phased array, or you can get away with a curved array probe. Again, just like the cardiac, we're shooting between the ribs, so phased array is probably going to be the best for most of it. If you're doing solely a lung slide exam, you could use the linear array probe, or if you're assessing a small child, the linear. Again, as a review, the linear is going to be higher frequency, so you get better resolution, but less penetration. So if we're trying to look at structures deeper within the chest or in the abdomen, we're going with the curvilinear or phased array probe. So ideally, if we have time, we'd like to do, our goal should be to do a little bit of a comprehensive exam here. I want to look at all those quadrants you see labeled there. If I'm pressed for time, if I'm doing this assessment as part of a rush exam or a cardiac arrest or somebody who's critically ill where time is of the essence, the views that I think are going to give the most info in the shortest amount of time is going to be R1 and L1, and then L4 and R4. So I'm going to be looking at those four quadrants very rapidly, assessing for some or all of those three major items we see on our screen. So lung sliding, which is going to tell me, are my lungs up or down? Do I have a pneumo? Do I not? A lines versus B lines, which is just saying, do I have air? That's what we call A lines. Or B lines, do I have fluid? And then again, that's only telling me that I have fluid. It's up to the provider to then determine what type of fluid I'm dealing with, whether that's cardiogenic or non-cardiogenic pulmonary edema, is it localized to one area versus the other, etc. And then do I have extrapulmonary fluid and effusions, which we're going to be looking mainly for those in that L4, R4 region, because that fluid is going to accumulate first in those dependent areas against the diaphragm. So in our normal pulmonary exam, so this is a phased array probe. Where I have this probe right now, I'm looking at, this is what it's going to look like for R1 and L1. So the probe is going to start right where you would decompress. That's a good an anterior decompression, I should say. So our old school decompression landmark, that's going to be a good spot to start. The probe marker is going to be pointed towards the head. You're going to shoot in between the ribs, and you're going to be looking for a couple of things. So you can see the red arrow there. You can see that bright hyperechoic line that is sliding back and forth. That is lung sliding. That is the pleural lining moving as the patient is breathing in and out. So that's normal. We want to see that. The absence of that would be concerning. As you get better and more advanced, you can look at the pleural lining and you will start to notice, because it should be somewhat uniform in size and should have a certain amount of thickness to it. And when it starts to get inflamed, it can look thicker than normal, and it can look irregular in pattern. This will tell me something that this might clue you in that your patient has pleurisy or pneumonia or something like that, or some sort of infectious type etiology. And then I've got the arrows showing those concentric horizontal lines. Those are A lines. What you're seeing there is actually artifact. So it is, if you notice, the brightest of the horizontal lines are equidistant, and so that's because it is a echo of the pleural lining. It's being reverberated through the lungs, and so that tells me that I have air in the chest. So if this was a trauma patient or a cardiac arrest or something where I'm trying to verify that my lungs are up, I'm going to throw that probe on, I'm going to look, and I'm just going to look for that lung side, I'm going to see that air, and I'm going to move on. In a patient who has shortness of breath, where I'm not sure, am I dealing with CHF exacerbation or pneumonia or asthma, I might do this exam in multiple spots. It might take a little bit more time, but that tells me right there that in a very rapid assessment that I have a lung that is up and it is full of air and not fluid. Okay, so you got two different shots here. These are shot from the same location. So on the left, you have your normal lung exam we were just looking at. You can see the horizontal A lines. I can see my lungs sliding back and forth. And then on the right, you see a little bit different. I don't see those horizontal lines, the A lines, and instead I see these vertical beams that look like light shining through water, which is a good mnemonic to clue you in on these B lines because they indicate fluid. So The memory mnemonic there is if you see light shining through water, then remember water, so your lungs are full of fluid. Now, the question here would be, do I have these present bilaterally? And are they present in the lower and upper lobes? This is going to tell us whether if it's present bilaterally, that increases the sensitivity to interstitial edema comparative to, say, if I had it only in a specific consolidated location, then I might be thinking something like a pneumonia or some different type of etiology here. That is a great example of air versus fluid. And so how I can use this quickly when treating a patient, say it's a respiratory patient, unknown, I'm not sure, what am I dealing with? On top of some of the other exams that we have and we'll talk about, like the cardiac and IVC assessment, if I have a patient that is in occult respiratory distress and I'm trying to determine a treatment pathway, this can clue me in very quickly, especially when the lung sounds are kind of that mixed grab bag. We hear a little bit of wheezing. We also hear rhonchi and fluids, and just kind of they're non-specific lung sounds, or your physical exam really isn't giving you enough to go on. Maybe the patient has a history that would fit a couple of different potential differentials. This can help to improve our diagnostic capability and pick a pathway. Because if our patient presents, say, hypertensive and has a history of heart failure, but then also has maybe a history of COPD, and they're hypertensive and hypoxic and short of breath, we have to ask, are they hypertensive? Because the hypertension a secondary issue to the stress response from the hypoxia and the shortness of breath, and that this is actually a COPD exacerbation, or perhaps the hypertension was the causative element that caused left ventricular systolic dysfunction and then elevated alveolar capillary pressure and then interstitial edema. And so that, again, two very different treatment pathways. And one, I'm going down the obstructive pathway. The other, I'm going down the like the SCAPE pathway, or sympathetically crashing acute pulmonary edema patient. So quite a bit that I can get right out of those two views. And in both, I can tell that my lungs are up, so I can rule out pneumo as a potential cause. Here's just a better example, or a still image. Kind of, this is a curvilinear probe, but still showing you those very noticeable B lines. One other thing I forgot to mention is often in significant edema, it will obscure the A lines and you won't see them at all, which is just a further demonstration that you have an abnormal pulmonary exam, that your lungs are not full of air. At the top, you can see that your pleural lining looks very uniform in density, and so that would most likely be pulmonary edema as the cause, interstitial edema. And again, don't forget to scan. Here's just a couple more examples, but don't forget to scan. And if I do have B lines present, I want to at least shoot in those 4 quadrants, if not as many as possible, to see the extent and presence of these B lines in various locations. The number one way to improve the sensitivity and specificity of any ultrasound exam is to get multiple viewpoints from different locations to confirm. So what I did here is I zoomed in, because the lung sliding is a kind of a subtle finding at first for people. It's hard to kind of know what you're looking at. So I've zoomed in. You can see 2 ribs. One I have labeled in green there. And so ribs reflect, the ribs are made of bone, so they reflect, they're majorly hyperechoic, so they reflect the ultrasound and nothing gets past it. So they actually, so while you would expect the entire bone to shine bright and white on ultrasound, only the top part is going to, or the part facing the probe, because it's going to reflect all of the beams back, and there's going to be nothing beyond it, and so you will get a shadow that casts, which is why it's so hard to get thoracic ultrasound images compared to other parts of the body, because you have to shoot your beam in between these ribs, which are going to block the ability to look more deeply into the lung. So I zoomed in here to show you that seesaw pattern, that motion of the pleural lining. It's also important, if you're in very obvious signs like this, you can move on. But if you're not sure if you have a pneumo or not, so the presence of lung sliding is very obvious, but the absence of it to a novice provider isn't always as easy to tell. And so there's 2 things that you want to do. First, if you see some motion, you want to ask, is that motion back and forth? Is it ebbing and flowing with the patient's spontaneous breathing or mechanically ventilated breaths? Is it in that same timing? So if there's 16 breaths per minute, do you see it kind of seesawing back and forth at the same rate, or is the motion more quick, faster than that? If it's small twitches that are occurring, let's say every second or much more rapidly, that's what we call lung pulsation or lung pulse. And what you're seeing in that case is just the heart is causing a ripple effect through the lungs, and you're actually picking that up on ultrasound. And so that's called lung pulse. And it's very subtle, but that would even so. And the only reason I say that is sometimes people are taught that there's absolutely no motion in a pneumo, but there can be that little twitch, and what you're just seeing is the heartbeat kind of echoing through the chest. So that's all you're looking for, is the movement at the same rate as the breathing pattern, or is there no movement, or is there that little twitch that's occurring, say 60 to 100 beats per minute, which would tell you that you might have a pneumo. If you're ever unsure, so if you're doing your pulmonary assessment and you're looking for lung siding and you're not sure, do I have a pneumo or do I not? There's an extra step we can take. We put it in M mode, which is just motion mode. In M mode, which gets used in all kinds of different ultrasound assessments, especially in cardiac. But all M mode is doing is it's taking one image at a time, and then it is splicing them together over time. Hence the motion. So imagine almost it's like a snapshot that's occurring multiple times in the same location. So you're going to throw it in M mode. When you do, you're going to see a dotted line. You can actually see the vertical dotted line at the top of that image there. You can move that, and you want to make sure that dot, those white dots, are shooting in between the ribs. If you don't get it in between, if you were to put that dotted line on the ribs, it would mess up the ability to measure this. And then you're going to hit the button again, and it's going to start screening this image across your screen, and it will continue to repeat it just like a continuous ECG monitoring type thing. And so what you're looking on the left is a normal, and so what you're seeing is, you should notice a noticeable division where the horizontal lines, which change in their opacity, you can see some that are darker and some that are brighter, but right below the brightest line, which, by the way, that bright line represents the pleural lining, below that it looks sandy, it's grainy. Above it, it's not. And the reason for that is the parts above that bright line are your soft tissue. That's the fat, the muscle, the intercostal muscle, the bone. That is the things that aren't moving. And so it's going to look static, and so you get that line. The lung is moving with each snapshot, and so it's going to be each image is going to be slightly different. And so while you can't see the slices on your screen, that's going to end up looking like splotchy grains of sand. They sometimes call this the beach or ocean view, where it looks like you're almost sitting on a beach looking out at the ocean. And so if you're an imaginative person, you can maybe see that. In a pneumo, because the lung isn't moving, or there'll be very minimal motion, you'll lose that sandy imaging, and instead you'll see that, they call it the barcode sign, but you'll see that the horizontal lines continue beyond the pleural lining. And so you can see an example of that there. Now again, it won't always be perfect, because the heart will still be beating in the chest, hopefully, depending on if the patient's alive. And so that heartbeat will cause a little bit of motion. So you can have some, but you can notice a very significant difference between the image on the left and the right. So how do I use this with a patient when I'm, with a sick patient, where I'm not doing this on every single exam? I'm doing this if I'm to confirm my suspicions that I have a pneumo. So I'm throwing the probe on. If I see obvious lung slide, I move on. But if I don't see obvious lung slide and I'm not sure, and I'm trying to determine, is this a thoracostomy candidate or something thereof? Maybe it's a cardiac arrest patient. Maybe I'm trying to determine if my tube's in the right place or something. I might throw this M mode on just to confirm. And by the way, it doesn't, all that the barcode, or I put barcode equals pneumo, but that's not entirely true. Barcode equals no motion. So it's a good example. If I threw this over the left lung in a patient I just intubated, it might mean that I just simply right mainstem my patient. Doesn't necessarily mean that you have a pneumo. All the barcode sign means is there's no motion. It means the lung is not moving up and down. So if it's a spontaneously breathing patient who was just ejected out of a motor vehicle crash, very likely you have a pneumo. If it's a patient you just intubated, look at your tube depth, make sure that you didn't right mainstem. If you rule out those things, then you may in fact have a pneumo, or your patient doesn't have a left lung or right lung, or has a lobectomy, or something is causing there to be an absence of motion. That's what you're seeing when you look at that. But very obvious when you throw it in mode. The last part, for this view, I'm going to have, so how I obtain this view, I actually put it in fast mode, which again, you can leave it in lung mode, you can put it in cardiac mode, it doesn't really matter, just kind of your preference. But the probe in this case is up in that it's about the sixth intercostal space, where I would do the beginning of a fast exam. So sixth intercostal space, mid-axillary line. The probe marker is pointed towards the head. It could also be pointed towards the feet. It doesn't matter. It just needs to be horizontal. It needs to be the probe needs to be horizontal or longitudinal. It needs to be in plane with the patient's body, not perpendicular to the plane. And so you'll get this image here, and you can see the liver, you can see the kidney, you can see the vertebrae of my spine, and then you can see the diaphragm towards the left side. And then on the other side of that line, you see mirror artifact. All of this is normal. In fact, you can notice at the diaphragmatic line, you notice you lose the spine, and you see what looks like a second liver, and that is that mirror artifact. That's simply intact lung tissue full of air causing this artifact and kind of tricking the machine. Because you have that bright diaphragm, it tricks the machine in the ultrasound and causes this artifact where it thinks it's detected. It's actually it is an echo or reflection of the liver echoing into the thoracic cavity, and so you're getting that view. But the clear determinant is you lose the spine, which tells you that it is artifact and that it's not continuing on. In fact, if the spinal column can be seen in the thoracic cavity, so superior or cephalic to the diaphragm, that's something called the spine sign, and is predictive that you may have a pleural effusion or you have fluid or some sort of abnormality in the lungs. It's actually allowing you to look at the lung tissue. Remember, in a normal pulmonary exam, you're never actually seeing lung tissue because the lungs are full of air, and air is not conducive to ultrasound. It causes the waves to echo and irradiate in a non-linear format, and so you get artifact, and so that's an expected normal finding. When you are seeing into the lungs, that is always abnormal, whether that be a pneumonia or interstitial edema or pleural effusion, is dependent on a bunch of factors, including patient history and what you're looking at, but it's certainly abnormal. So here's just a unlabeled clip of the patient breathing in and out. And so this is a normal finding. Again, you can see the liver, you can see the kidney, you can see the mirror artifact, the diaphragm, and you can see that you lose the spine as the diaphragm moves inferiorly as the patient breathes in. It's a normal finding. That is that mirror artifact. That is the thoracic cavity moving and obscuring your view, and then as it recedes, you're getting to see the spine again. Okay. In this image, you can see same view, different patient, but same view. You can see the spine continues all the way up past the diaphragm. It shouldn't do that. And then you see this hypoechoic fluid, black, that is cephalic to the diaphragm. That's telling you that you have a pleural effusion. If you saw that same hypoechoic material in between the liver and the kidney, say in a trauma patient, that would be most likely intra-abdominal bleeding secondary to trauma. It would be a positive fast exam. So this is very similar exam. You're looking for different things in different patients, but that can help, again, to clue us in on what we're dealing with. These are also good images to save and to save loops, especially if you're a transport provider, because this can help clue the provider in on how they would like to do, whether or not how they would address the centesis, and if there's any sort of complications. Sometimes there can be that not all pleural effusions are cut from the same cloth, and so there can be barriers and complications to a centesis. So these images are actually very helpful to kind of clue them in on what we're dealing with, how big of an effusion we have, and if there's any barriers. Sometimes there can be extra attachments where the lung is attached to the diaphragm abnormally, and that can cause difficulty in that process. And here's just an example of a much smaller one. So again, this is a curvilinear probe shot from a little bit of a different angle, but you can still see the same major structures, liver. You can see the spine kind of oscillating up and down at the bottom, and then you can see that effusion shining up into the diaphragm there. Okay, so when I'm doing a pulmonary assessment, it depends a little bit on what I'm doing. Is this a rapid assessment, just looking for new mode, verify tube placement, rule out causes of cardiac arrest, or is this an alive patient where I'm doing a differential on why they're having maybe difficulty breathing? And so when I look at that, I'm going to verify lung sliding. I can do that with placing the probe where you would do an anterior decompression with the probe marker up, looking for lung sliding. Don't forget about M mode if you're not sure. As far as my pulmonary differential, can look for A lines versus B lines. Do I have those concentric circles that show me, those horizontal lines that show me that I have air versus I have fluid if I see those vertical B lines going through. And then also I can locate the diaphragm and then assess for effusions. And kind of going back just one last little thing is, if I really want to improve this, I keep kind of harping on the same thing, but a wholesale exam is going to improve your specificity and sensitivity. So again, if I have a patient with shortness of breath and I do a pulmonary assessment and it's normal, meaning I have good lung sliding and I see air in both lungs, and then I do a cardiac assessment and I see significant RV dilation, and then I do my IVC assessment and I see that it is non-collapsible, that's going to point very heavily towards something like pulmonary embolism, pulmonary hypertension, things of that nature, which is a completely separate treatment pathway than if I were to see air in the lungs. Say I have A lines and normal pleural sliding, lung sliding, but my cardiac assessment and my IVC are unremarkable, or maybe even my IVC is collapsing and my cardiac assessment, it just shows hyperdynamic wall motion, which is going to tell me that I have some sort of respiratory etiology that's going to point more towards obstructive lung disease or perhaps pneumonia or something, which would then come down to the physical exam as well. So those are just some examples of how I can incorporate that pulmonary assessment very rapidly into my emergent care of a patient.